Hello everyone, I welcome you all to this session on fluid and electrolyte balance, which is a very important topic. So before we move on to our discussion on electrolytes, today we'll be looking at some of the basics of fluid management and basics of total body water and so on. So let's begin. So the first concept that we should be knowing is the concept of total body water. So the first concept that we should be knowing is the concept of total body water. So what is this total body water? So it basically refers to the total amount of water which is contained in our bodies. So in males it's about 60%, in females it's about 50%, and children the total body water can go up to 70%. So this you would have learnt in your basic physiology. What is this total body water? So it comprises of two portions. The intracellular, IC basically stands for intracellular, and the extracellular or the EC, which is your extracellular portion. So the amount of fluid intracellular is your IC and your EC. The extracellular fluid comprises of again two portions, which is your interstitial fluid and your plasma. So the extracellular fluid comprises of two portions, which is your interstitial fluid and your plasma. So when you look at the percentage of distribution of the total body water, the 67% of TW, the 67% of the total body water is in your intracellular, whereas 25% is in your interstitium and 8% of the total body water is in your plasma. Okay, so the maximum amount of total body water is contained within your intracellular fluid. 25% is your interstitium and 8% is your plasma. So the plasma is nothing but what is the fluid which is contained within the vasculature, Of the extracellular fluid, 3/4 of it is your interstitium and 1/4 of it is your plasma. So out of the extracellular fluid, 3/4 is your interstitium and 1/4 is your plasma. So this basic understanding is a very important concept, okay, of total body water. Now let's move to your second portion, which is your distribution of your total body water. You understood what is the interstitium, what is the plasma, what is the intracellular fluid. Now let us look at what are the type of solutes that you find within your total body water. So the first, can you see here that this is nothing but your sodium potassium ATPase? This is nothing but your sodium potassium ATPase. So the function of the sodium potassium ATPase is that it pumps in potassium into the intracellular fluid and it pumps out sodium. So potassium is a highly intracellular ion. Potassium is basically intracellular ion, whereas sodium is predominantly extracellular in nature. Second, can you see that the water molecules can permeate the intracellular as well as the extracellular components easily? That is, the membranes, which is your membrane between the intracellular and extracellular, and the membranes between your interstitium and plasma is freely permeable to water. So water can move freely between all the three components. So water can move freely between all the three components. Okay. The third, number 3 is your proteins. You can see that proteins are predominantly present in the plasma. So the proteins are impermeable. That is, the membrane is impermeable to the proteins. The membrane between the plasma and the interstitium is impermeable to the proteins. So the proteins are predominantly present in the plasma. And the fourth most important thing that you should be knowing is that the osmolality between the intracellular, the interstitium, as well as the extracellular, that is, the intracellular, the interstitium, as well as the plasma is equal to one another. That is, there are three components, right? The intracellular, the interstitium, and the plasma. The osmolality in each section is equal to one another. Osmolality of each is equal to one another. Okay. So that is about the distribution of the total body water. Now, let us understand what are the solutes. We know that the total body water comprises of solutes as well as water. So the solutes which are dissolved within it are of two types. We have the electrolytes and the non-electrolytes. Right, so we have the electrolytes as well as the non-electrolytes. The electrolytes include positively charged ions. The positively charged ions are the cations. and the negatively charged ions are the anions, right? So it has H plus, magnesium, sodium, calcium are all the cations, whereas the phosphate, chloride, bicarbonate are all the anions. Then you have the non-electrolytes, which include substances like urea, glucose, proteins and albumin. So these electrolytes and non-electrolytes are basically the solutes which form the part of the total body water. So that is about your solutes. Okay. So I hope you have understood the first concept. So we have learned what is the total body water. So on an average, the males have a total body water of 60%, females have a total body water of 50%, and in children can go up to 70%. What are the components of total body water? It comprises of the intracellular as well as the extracellular fluid. 67% of the total body water is by the intracellular and 25% is by the interstitium and 8% of the total body water is your plasma. So the extracellular fluid comprises of the interstitium and the plasma. 3/4 of the extracellular is by the interstitium and 1/4 is by the plasma. Okay, we have understood about the distribution. Because of the sodium-potassium ATPase channel, the potassium is a predominantly intracellular ion, the sodium is predominantly extracellular. Water is freely permeable through all the sections. Proteins are predominant constituent of the plasma, and the osmolarity of the intracellular is equal to the interstitium, which is equal to the plasma. Okay, and we have also understood the concept of the electrolytes and the non-electrolytes which form a part of the total body water. Now let us move on to the next concept. We move on to the concept of plasma osmolality. So what is osmolality? It is the number of particles or osmoles dissolved per liter of the solution. So we know that this component is nothing but your electrolytes. This is your non-electrolytes. So this is your electrolytes and this is your non-electrolytes. So the sum of your electrolytes plus non-electrolytes, the sum of your electrolytes plus non-electrolytes is what gives rise to your plasma osmolality. Right, so the number of particles or osmoles per liter of the solution or the number of electrolytes and non-electrolytes gives us your plasma osmolality. So how do you measure your plasma osmolality? So this is done by what we call as the freezing point depression method. This is called as your freezing point depression method. Okay, so osmolality is measured by your freezing point depression method. But there is also another way of calculating the osmolality. So how do you obtain your calculated osmolality? It is obtained by this given formula. So we know that this is your electrolytes, this is your non-electrolytes. So to obtain the plasma osmolality, we should be knowing the total amount of electrolytes. Now the most predominant electrolyte is your sodium. Okay, so if you and the contribution of the osmolality by the other ions is very less. So if you just take 2 into sodium or twice the sodium, you get your electrolytes in millimoles per liter. Then we take 2 other non-electrolytes in the calculation of the osmolality, which is your blood urea nitrogen 1 and glucose. Okay, so these are the 3 molecules which are used in the calculation of plasma osmolality. So the formula is given by 2 into sodium plus 1 in milligram per deciliter and glucose in milligram per deciliter. So this is just an assumption. The calculation is brought about by means of an assumption that the most prevalent electrolytes and non-electrolytes help in the contribution to the plasma osmolality. Okay, now what is this formula? Right, so how do you convert the milligram per deciliter into millimoles? You multiply it by 10 and divide it by the molecular weight of the substance. You multiply it by 10 and divide it by the molecular weight of the substance in order to convert milligram per deciliter into millimole per liter. Right, so it is 2 into sodium plus 1 into 10 by 28, which is the molecular weight, and glucose into 10 by 180, which is the molecular weight of glucose. So this is the formula which is used for the calculation of the plasma osmolality. So the actual plasma osmolality is brought about by the freezing point depression method, but everywhere you will not be able to use this freezing point depression method. So the other way that you can use it is your calculated osmolality, which is given by 2 into sodium plus Bun into 10 by 28 or Bun by 2.8 plus glucose by 18. Okay, fine. So let us understand this. For example, the patient's sodium is 140, Bun is 10 and glucose is 80. So how do you calculate the osmolality from this? It is given by 2 into 140 plus 10 by 2.8 plus 80 by 18, which comes out to approximately 288 millimoles per liter. Right? So the normal plasma osmolality is given by 280 to 290 millimoles per liter. What is this concept of osmolar gap? So what is this concept of osmolar gap? Osmolar gap basically refers to the measured minus the calculated serum osmolality. So this is given by measured minus the calculated serum osmolality, and normally this is less than 10. If it is more than 10, this means that, so there are certain other substances which are contributing to this osmolar gap, substances like ethanol, lactic acid and ketone bodies. So substances like ethanol, lactic acid and ketone bodies can result in this high osmolar gap. Okay, so this is the concept of osmolality. How do you calculate osmolality and what is the concept of osmolar gap? Okay, fine. Let us move on to concept number 3. So the third concept is your concept of IV fluids. Let us understand the different types of IV fluids and the utility of the various IV fluids. So the first IV fluid that we should be knowing is your 5% dextrose. The 5% dextrose is given by this, which is your D5W, which means that, as you know, 5% basically means that 5 grams of dextrose dissolved in 100 ml of water. Okay, so this basically means 5 grams of dextrose dissolved in 100 ml of water. So this is what is referred to as the concentration. Then the osmolality of 5% dextrose is around 278 millimoles per liter. So we have just learnt that what is the normal serum osmolality. It is around 280 to 290 millimoles per liter. That means what? This is isoosmolar. That means what? This is almost isoosmolar to the plasma. So this is a good IV fluid because it is almost isoosmolar to the plasma. Now let us understand the distribution of 5% dextrose. So this is your 5% dextrose packet around 1 liter. This is your total body water representation. So whenever you give about 1 liter of 5% dextrose, 67% of it goes into the intracellular, 25% of it goes to the interstitial and 8% goes into the plasma. Okay, that means that 5% dextrose, when you administer it, it gets distributed into all the 3 components of total body water. It goes into the intracellular component and it goes to the extracellular component. So what is your implication of this IV fluid, right? So can it be used for volume replacement? We know that only 8% goes into the plasma, right? So that means that only around 80 ml will go into the plasma. So is it a good plasma expander? For example, in patients with shock, in patients with, for example, hypovolemic shock, will you give dextrose as the first line of treatment in the treatment of shock? No, because the amount of dextrose that goes into the plasma to maintain the plasma volume is very, very less, right? So this is not a good choice. This is not a good choice for plasma expansion, right? So it is not used for plasma expansion, okay? But we know that whenever we give dextrose, the dextrose is converted into carbon dioxide along with heat. So it is metabolized into carbon dioxide along with heat, and the rest of it is nothing but your water, right? So whenever we give dextrose, what does this mean? It means that this IV fluid, 5% dextrose, is equal to giving water, is equal to giving free water, because the dextrose is metabolized into carbon dioxide and heat, and what we are left with is water. So whenever we administer 5% dextrose, it is equal to giving free water. So what is the use of this? This means that it can be used in the treatment of hypernatremia. Because it is equal to giving free water, it can be used in the treatment of hypernatremia. Okay. Now, calories, we know that when it comes to the calories which is given by 5% dextrose, 5% dextrose is nothing but 5 gram in 100 ml or 50 gram per liter. So we know that per gram of glucose you get around 4 kilocalories. So for 50 gram we get around 180 kilocalories. But so can we tell that 5% dextrose can be used as a calorie supplement? No, because a normal individual requires about how many calories per day? He requires about 2000 calories per day, right? So how many liters of 5% dextrose have to be infused? If this is around 200, then you will require up to 10 liters of 5% dextrose just for the caloric requirement. So is it possible to use 5% dextrose for calorie replacement? No, it cannot be used. So it's very few amount of calorie which is given by 5% dextrose. Okay, so it's not used for volume replacement, it is not used for caloric requirement, it can be used in the treatment of hypernatremia. Okay, so that is about 5% dextrose. Now let us move on to the next IV fluid. The next IV fluid is your normal saline. So the normal saline is available in 3 different concentrations, which is your 0.9%, 0.45% and your 3% normal saline. So normal saline is basically available in 3 different concentrations, which is your 0.9%, 0.45% and 3%. So 0.9% comprises of how much sodium? It has equal amounts of sodium and chloride, 154 milliequivalents per liter of sodium, 154 of chloride and an osmolality of around 308. So if you take the normal serum osmolality, it's around 280 to 290. So this we can say that normal saline is almost isotonic to plasma. When you see 0.45%, 0.45% has 77 milliequivalents of sodium, 77 milliequivalents of chloride and total osmolality of 154. So this is hypotonic. When you see 3% NaCl, it is about 513 milliequivalents of sodium and chloride and it is a hypertonic solution. So you just remember that 0.9% NaCl is the most commonly used normal saline concentration and it is isotonic to plasma. 0.45% is hypotonic and 3% is hypertonic. And you should be remembering the amount of sodium and chloride which is present in it. Okay. Now let us look at 0.9% NaCl. What is the meaning of this 0.9% NaCl? That means that 0.9 grams of sodium chloride is present in 100 ml of water or 9 grams in 1 liter. Okay. Now let us take this 1 liter bottle and let us see how this NaCl 0.9% saline is distributed. So this 0.9% NaCl does not go into the intracellular space, right? So it predominantly restricts itself only to the extracellular. So it predominantly restricts itself only to the extracellular component. So we know that the extracellular component basically comprises of 3/4 of the interstitium and 1/4 is the plasma. So 1 liter, 3/4 means 750 ml here and 250 ml here, right? So what is the implication is that this can be used in shock. Why? Because it improves the plasma volume to a large extent. As compared to dextrose, you can see that this improves the plasma volume to a large extent, right? So this can be used in shock. That's why this is the most common fluid which is used in the initial stages of shock to improve the blood pressure and to improve the effective circulating volume. Okay. Now let us understand 0.45% NaCl. So in this 0.45% normal saline, what is it? It is equal to 500 ml of 0.9% NaCl along with 500 ml of water. So if you take 0.45% NaCl to obtain this concentration, we take 500 ml of 0.9% NaCl and you add an extra 500 ml of water to it, it becomes 0.45% NaCl, right? So let us understand how this is distributed in our body. So 500 ml of water, Whenever you take 500 ml of water, it is going to get distributed to all the 3 segments. So 67% is intracellular, 25% is interstitium, 8% is your plasma, which means 335 ml, 125 ml and 40 ml. Now 500 ml of 0.9% NaCl, we have already seen that 0.9% NaCl does not move into the intracellular. It is predominantly located only in the extracellular component. So it will be 375 ml in the interstitium, which is 3/4 of 500 ml, and 125 ml in the plasma. Okay. So we have understood this much till here. Fine. So what is the implication of this? So the implication is that it can be used in the treatment of hypernatremia. Similar to dextrose, because 0.45% NS is also associated with giving free water to the intracellular compartment, it can be used in the treatment of hypernatremia. Okay. This can also be used as a part of the plasma expansion, but it does not expand it so much. So it is not the first line therapy, but it can be used as a maintenance fluid. It can be used as a maintenance fluid in hospitalized individuals whenever they are having some amount of fluid loss, which can be insensible loss, or there can be some amount of diarrhea and so on. So this can be used as a maintenance fluid in such cases. Okay. So it can be used in the treatment of hypernatremia. All the dilutions of the antibiotics which you are giving in a patient with hypernatremia, for instance, the antibiotics can be diluted in half NS. Okay. It can be used as a maintenance fluid as well. So this is about your half NS or your 0.45% NaCl, what we call as half NS. Alright. So this is about your 0.45% NS. Now let us look at the next IV fluid. So what about 3% NaCl? 3% NaCl is nothing but a higher concentration. So it is 3 grams of NaCl in 100 ml of water. So it's a very high concentration. So when you give 3 grams, there is so much of sodium here. What happens? The water starts moving from the intracellular to the extracellular compartment. So water starts moving from the intracellular to the extracellular compartment because this goes along the concentration gradient. Because of the extreme tonicity of the surrounding area, the water starts moving from the intracellular to the extracellular compartment. So what is the implication? This is used in the treatment of hyponatremia. This is used in the treatment of hyponatremia. Okay, fine. Clear till here? Now let us see the next IV fluid. So the next IV fluid is your lactated ringers or ringers lactate, which we call as RL. So what is the composition of your lactated ringers? So ringers lactate, which basically comprises of sodium at around 130 milliequivalents per liter, chloride of 109, potassium of 4, and it has lactate at 28 milliequivalents per liter. Sodium of 130, chloride of 109, sodium of 130, chloride of 109, potassium 4 and lactate 28 milliequivalents per liter. And as you can see here, the osmolality is 274 millimoles per liter. So which means that this is also almost an isotonic fluid. So you can see that this is also almost an isotonic fluid. Okay. So if you take this lactated ringers, this is also similar to NaCl as well. So it does not have any penetration into the intracellular fluid and it is predominantly an extracellular fluid. So this can be used in shock. Okay, this can be used in shock. It can be used in diarrhea. So this helps in volume replacement because a good amount of the lactated ringers goes into the plasma. So this can be used in volume replacement. So what are the contraindications? Severe lactic acidosis. Severe lactic acidosis is a contraindication to the use of lactate, use of RL because of the high amount of lactate in RL. So severe lactic acidosis is an important contraindication for the use of ringers lactate. Also liver damage. Whenever there is liver damage, we do not give lactated ringers. So the IV fluid of choice in shock, in hypovolemic shock, is first your 0.9% NaCl followed by your RL. What is used as a maintenance IV fluid? It is your half NS. Okay. Which IV fluid is used in the treatment of hypernatremia? It is 3% NaCl. Which IV fluid is used in the treatment of hyponatremia? It is your 5% dextrose, which is similar to giving free water, as well as your half NS. Okay. So this brings us to the end of your concept on IV fluids. Alright, so till here clear. Now let us move on to the next concept. The next concept is your concept of volume regulation and osmoregulation. Okay. So let us understand this term, what is effective circulating volume. So what is effective circulating volume? Effective circulating volume basically refers to your plasma volume and blood pressure, right? So what is the aim of this effective circulating volume? It helps in maintaining the perfusion pressure. So effective circulating volume basically comprises of your plasma volume and the blood pressure. So what is the main aim of this effective circulating volume? It helps in maintaining the perfusion pressure. So what is the main aim of this perfusion pressure? We know that all the vital organs such as the brain, the kidney, all of them require a certain amount of perfusion. So to maintain this perfusion, you require a certain amount of blood pressure. It has to be maintained between 80 to 120 millimeters of mercury. The moment the blood pressure begins to fall less than 80, the person goes into shock and the perfusion is lost. So the main aim is that the effective circulating volume helps in maintaining this perfusion pressure. Okay. So whenever there is a low blood pressure, let us understand the mechanism by which this effective circulating volume is maintained. So whenever there is a low blood pressure, first thing is that the baroreceptors are stimulated. Baroreceptors, as the name suggests, they are barocentric, which means that they detect the changes in the blood pressure. So when the baroreceptors, which are there in the carotid sinus, as well as in your glomeruli, when they are stimulated, it causes stimulation of three systems. It causes stimulation of three systems, which is your renin-angiotensin-aldosterone system, then it causes stimulation of the sympathetic pathway, and it causes stimulation of the antidiuretic hormone. Okay. So what is the function of this RAS system? So RAS system basically means that we have a molecule renin, which is mainly responsible for the stimulating of angiotensinogen. It basically causes stimulation of angiotensinogen to angiotensin 1. Angiotensin 1 is converted into angiotensin 2. So what happens with this angiotensin 2? This helps in the reabsorption of sodium and water from the kidney. It helps in the reabsorption of sodium and water from the kidney, and it causes excretion of potassium. So when there is reabsorption of sodium and water from the kidney, it helps in restoring the blood volume. So when the blood volume is restored, it helps in increasing the blood pressure. Okay. The sympathetic system, when it is stimulated, again it is going to cause peripheral vasoconstriction and it is going to increase the core blood pressure. What is this antidiuretic hormone? ADH basically stands for antidiuretic hormone. So what is the function of this antidiuretic hormone? As the name suggests, it prevents diuresis. So if it prevents diuresis, it helps in improving the plasma volume. So we have two receptors. Antidiuretic hormone is also called as vasopressin. So we have two receptors, which is your V1 receptor, which is present on your vessels, and we have V2 receptors present in the kidney. So the main function of this V2 receptors is that it causes stimulation of this aquaporin 2 molecules. So this aquaporin 2 molecules are the one which basically help in your water retention. Okay, so the antidiuretic hormone acts on your aquaporin 2 molecules and it prevents excretion of water and it helps in restoring the plasma volume. Okay, so that is how your effective circulating volume is maintained. It is maintained by your RAS system, your sympathetic system, as well as your antidiuretic hormone. Okay, now let us understand osmoregulation. We have understood volume regulation. Let us understand osmoregulation. So whenever there are changes in the osmolality, what is stimulated? It stimulates the thirst center in the hypothalamus. There is a thirst center which is present in the hypothalamus, which is stimulated by small changes in the plasma osmolality. So when the osmolality is high, so the main aim is that the body tries and maintains the plasma osmolality between 280 to 290 milliosmoles per liter. So when the plasma osmolality becomes 300, for example, that means that the patient is dehydrated. So the plasma osmolality is beginning to increase. So this causes stimulation of the thirst center in the hypothalamus, and it helps the patient to drink water, right? It causes stimulation of the thirst center, and it helps the patient to drink water. So when you drink water, the osmolality is restored to normal. Also, it causes stimulation of the antidiuretic hormone, and it is stimulated means that it decreases the urine output. So in a dehydrated patient, in order to conserve water and in order to conserve the effective circulating volume, it stimulates the thirst center to drink water and it decreases the urine output. When the osmolality is low, which means that the patient is overhydrated, then there is inhibition of the thirst center and there is stimulation or inhibition of the antidiuretic hormone. So if the antidiuretic hormone is inhibited, there is diuresis. Okay. So this is about osmoregulation. Fine. So this brings us to the end of this chapter on the basics of fluid management. We have understood what is the various types of IV fluids. We have understood what is plasma osmolality, how do you calculate the plasma osmolality, what is osmolar gap. We have also understood about osmoregulation and volume regulation. We have also understood some of the basics of total body water. So this is a very, very important chapter. Please go through this before you go ahead and learn about various electrolyte disturbances. Thank you.